Thank you very much, Dr. Inji. Thank you very much indeed. Thanks a lot.
Thank you, Professor Dr. Tamer. Thank you.
Thank you very much. Now we proceed to our dear friend, Dr. Hussein. Dr. Hussein is a real friend. Hussein is Alsafaar. He's from Oman. He's a consultant pediatric endocrinology at Sultan Qaboos University Hospital, honorary associate professor, Wasit University, board member of the Oman Diabetes Association and the head of research committee. He's very active at the ISPI and the ISPAD as well. We have met several times, even last early this month. And his talk is about an overview regarding congenital adrenal hyperplasia. The mic is yours, my dear friend. Looking forward to hear your presentation.
Thank you very much, Professor, for the welcoming and the introduction. I hope the slides are obvious and clear with you. Can you just confirm that you could see the slides?
Yes, Doctor, it's clear.
Perfect, thank you very much. These are my disclosures, and I will take you through the outline. So we're going to talk about the adrenal anatomy and physiology and shed the light mainly on the steroid synthesis pathway with talking about the enzyme deficiency that we could see in patients with congenital adrenal hyperplasia, and depends on the time. I don't know whether we could reach the clinical cases later on or not. So adrenal glands are on the top of the kidneys, as everyone knows, and each gland weighs about 4 grams. But yet this gland is very important for the body. It forms of the cortex and medulla. The cortex has got 3 layers, the zona reticularis and zona fasciculata and glomerulosa. So for the glomerulosa, it forms about 10 to 15%, and the main bulk is for zona fasciculata, 75% of the cortex, and then the reticularis. The differentiation of these cells usually completed by 3 years of age, but for the zona reticularis, where the androgens are going to be formed, may take up to 15 years for the differentiation to happen. So on this illustration, basically the CRH, corticotropic releasing hormone, will stimulate the anterior-pituitary through the POMC, then the ACTH to be produced, and then the adrenocorticotropic hormone works on the mineralocorticotroph receptor 2, MC2R, and by doing that, also there is another similar receptor called MC1 receptor, which is available in the skin, and that's why when we have excess of ACTH, there will be stimulation of that receptor, leading to tanning of skin. So now by reaching the MC2R receptor with the ACTH, that would lead to stimulation of the process through G protein. G protein will work on the adenylate cyclase, and then the cyclic AMP will lead through the star protein for, guiding the cholesterol to enter the mitochondria. Biosynthesis will start to occur. It's a bit of difficult process, and sometimes for our residents and juniors may not be easy for them to memorize this pathway. So I would like to explain it in a simple way that I found it very useful and make it memorable. So basically we have this kind of illustration using the 6 blocks on the left column, and then 5 and 4. So if we have a close look to it, starting with cholesterol, this is the burger man. So cholesterol is the fundamental component for this pathway to occur. And then this cholesterol has got underneath to it, as we could see, a lion, but there's a bit fatty lion. Actually, it's not fatty lion. It's like a pregnant lion. So we call this component is pregnenolone. This is the way that it has been made easy to memorize. So for cholesterol to move into the pregnenolone, need to get rid of the lace. If you imagine this burger man wearing a shoes, and this is the shoelace, so make it memorable to have cholesterol desmolase for that enzyme to move the cholesterol to pregnenolone. And then underneath that pregnant lion, there's a projector, and that is to help us to memorize. This is a progesterone. Okay, and this line is standing on 3. So when we say 3, we remember the 3 beta HSD enzyme. So all the way through horizontally, you have the 3, which is the 3 beta HSD. And then with this progesterone, underneath it, there is a twin gun. So if we say this is a twin gun here, so that will remind us, we say twin, that's 21 hydroxylase. So 21 hydroxylase enzyme works on this kind of movement and transformation and reactions. So from progesterone with the twin gun, the 21 hydroxylase, there will be formation of, as you can see here, 2 doctors. So that one and another one here. So that like 11 doc, and that is made to remember that is actually the 11-deoxycorticosterone. And then underneath the 11-deoxycorticosterone, we have the 11-beta hydroxylase to remove those 11 from there. That will lead to corticosterone. And then we could look to this ugly face here. So that's called the synphase. And that synphase basically is like the aldosterone synthase. So basically the corticosterone through the aldosterone synthase will result into aldosterone. Here we go, we finished the 6 blocks from the left side, and that is the mineralocorticoid pathway. And then if we would like to move to the glucocorticoid pathway, so we need to move horizontally, to move from the pregnenolone to on the other side to get the 17-hydroxypregnenolone, you need to go through this door, and this door will go through by the heaven teen, like heaven teen. So that's heaven teen, remember, so with 17, then that's 17 hydroxylase. And all the way through from the left side to the right side, if you want to move crosses the doors from there, you need to have this enzyme, the 17 hydroxylase. So to remember 17 hydroxylase, remember the heaven teen. So pregnenolone, that's 17 hydroxypregnenolone, and this is progesterone, then will move to 17 hydroxyprogesterone. So if we carry on the right side, going through this way, so another heaven teen, another 17 hydroxylase, you could have the dahlia, so the deer here, we'll put a picture of the deer, the hydroepiandrostenedione. And if you want 17 hydroxyprogesterone to move to this side through the 17 hydroxylase, then you get the androstenedione, and we put like andro, and so that's for androstenedione. If we want to go downstairs from there, we reach 17 hydroxyprogesterone. So here now, earlier we said the 11 doc, and then we have the corticosterone. So now we have the 11-deoxycortisol. So remember, like a cortisol on the wall. So those 2 docs were not sitting in the boat anyway, they are hanging on the wall. So to remember the deoxycortisol. And then with the effect of the 11-beta enzyme, then the 11-deoxy is going to be removed, so ending up with just cortisol. And if this cortisol want to have a private zone, so that will be the cortisone. So from cortisol, get cortisone. And this is the glucocorticoid pathway. Now moving further on the right side with another heaven teen, we said the androstenedione there, and this is the strong man, is the testosterone. So the testosterone needs to be effective, and to be effective, that needs to be activated to result into the active form of testosterone, which is the hydrotestosterone. You need the 5-elephant, and the 5-elephant will remind you with the 5-alpha reductase. So with the effect of 5-alpha reductase, you get the dihydrotestosterone, which is the active form of testosterone. Now, this is a young girl called Esther. So Esther is playing with a drone. So that's basically the esterone. So from androstenedione with the effect of aromatase, you get esterone. And this Esther, the girl, is playing with the phone trying to dial. So that is the estradiol. And then the testosterone with the effect of aromatase will result into estradiol. So basically, this is the simplification of the such a difficult pathway to memorize, but now it is easy for everyone to go through it. And if we go by the most common type of defect in this pathway is when we have a mutation in a gene causing the defect in this enzyme, the 21 hydroxylase. So by far, this is the most common cause of congenital adrenal hyperplasia, 21 hydroxylase deficiency. So basically, there would be a defect into completion of the mineralocorticoids as well as glucocorticoids. On top of that, there would be like a diversion of traffic. If you remember, if you just imagine that you are on the way and there is a barrier with saying diversion because there is a blockage of this pathway, so you need to go on alternative way. Going through this alternative way means shifting all the chemical reactions toward the androgens pathway. And here we go from chemical point of view, you will get the 17-hydroxyprogesterone will be elevated, as well as the DHEA, as well as the testosterone for those cases. And we have other enzyme defects like 11-beta hydroxylase deficiency. So again, the problem is will result into informal completion of the mineralocorticoid pathways as well as the glucocorticoid. However, because this happened as a level lower, so we'll have the 11-deoxycorticosterone. So those patients with 11-beta hydroxylase deficiency, they will have accumulation of 11-deoxycorticosterone. And this 11-deoxycorticosterone has got an effect on the circulation of the body, leading to hypertension. So among the cases of congenital adrenal hyperplasia, if we have a patient with hypertension, then we should think of 11-beta hydroxylase deficiency. Otherwise, those patients would have either normal or low blood pressure. Now, if we the same thing will happen with this androgenization. Other chemicals, 17-hydroxyprogesterone will be elevated, as well as DHEA and testosterone. Now, if the level that is where the defect is happening at the level of 3-beta HSD, so that's a bit higher up there. So the defect will be in all three pathways: the mineralocorticoid, glucocorticoid, as well as the androgens. So in all situations, if we have a defect in the enzyme synthesis, CRH will be continuously stimulating the POMC and ACTH. ACTH will be produced extensively, trying to stimulate the adrenal that is not working. So basically, there will be accumulation of ACTH into the circulation, and the gland will be appears with hyperplasia in response to that ACTH, hence the name of congenital adrenal hyperplasia. Now, as we said earlier, the 21 hydroxylase deficiency is by far the most common adrenal enzyme disorder. A newborn screening program in place in more than 50 countries so far worldwide. The Endocrine Society had produced a guideline in 2018, which is adopted by the SP and other societies. So basically, there is a recommendation that the newborn screening should be including the 17-hydroxyprogesterone to detect early cases that could be presented with severe CAH. The incidence is variable between 1 to 2,500, like in Eskimos. Otherwise, in the rest of the world, it's between 1 to 15,000 to 1 to 30,000. In India, for example, especially when they started newborn screening, they discovered that the incidence rate is a bit higher than it was expected before. It's 1 to every 5,762 child. In MENA region, Middle East and North Africa, unfortunately, we haven't got the clear statistics to tell us what is the incidence in our region. So we need to work hard on that to reach what is the incidence and diagnose patients for early. Now, with this 21 hydroxylase deficiency, as was explained earlier, you can see the sketch here to remind you about the pathways. But the gene that is causing this, called CYP21B gene, which is located in chromosome 6. So the presentation of the patients can be classic or non-classic CAH. The classic CAH is the salt-losing one, when the 21 hydroxylase deficiency but it's almost complete. So there's no much left of this enzyme. Whereas if there is a little bit has been left of this enzyme, like about 1 to 5%, the 1-to-1 hydroxylase is still there. So that could preserve and could reduce the severity. So the patient will be presenting with non-salt losing congenital adrenal hyperplasia. On the other side, we have the non-classical type, which is usually late onset and appears during the teenage. A patient could have features suggestive of PCOS, the polycystic ovarian syndrome, but the clinician should keep in their mind as a differential diagnosis to PCOS is the late onset non-classical CAH. And according to Tanner staging, so this is on the left side, that's the typical female genitalia. On the right side is typical male genitalia. And then there will be masculinization and virilization. So according to Tanner staging, if it's just clitoral hypertrophy, so that's grade 1. Grade 2 is clitoral hypertrophy with urethral and vaginal orifices present, but very close to each other. And in Tanner stage 3, here, then there's a clitoral hypertrophy, single urogenital orifice, a posterior fusion of the labia majora, and with type 4, there's a penile actually clitoris, perineal scrotal hypospadias, and complete fusion of the labia majora, and this is complete masculinization grade 5. Surgical indication has been almost, there's a consensus if the stage is stage 3 actually, and 3 and more. Now, as we mentioned earlier, briefly about the types of the CAH. So the salt wasting type is the severe form, which usually presented with severe virilization with fusion and scrotalization of labia majora if it's a female patient, and gross clitoral enlargement for females. It usually presents on the second week of life. A patient can be presenting with features suggestive of poor feeding, vomiting, poor weight gain, lethargy. That could be mimicking symptoms of sepsis. So, of course, they can be screened for sepsis and covered by antibiotics, but also the clinician should be aware that CAH is one of the possibilities here. So if there's a hyperpigmentation of the genitalia, so the thinking should be about CAH, especially if there is consanguinity in the history, because this is a kind of autosomal recessive conditions. The simple virilization form, usually the symptoms can be very mild during birth. Therefore, the case is often missed, but then during the 2nd to 4th year of age, there will be signs of androgen excess. So if a boy will be, the family will be complaining that there is enlarging in the size of penis unexpectedly for this age of the child, or clitoris will be having clitoromegaly, pubic hair development in such age, with other signs of secondary sexual characteristics and the effects of androgens, like the growth acceleration, the greasy skin, the acne, and the advanced bone age. Usually, precocious puberty can be attained due to priming of the hypothalamic pituitary axis with those androgens. So it starts like initially like a peripheral precocious puberty, but then it could change from peripheral into central, actually, precocious puberty. Early fusion of epiphysis could lead to a short person in the future, and the adult height usually will be below the mid-parent percentile. The non-classical one, we said, is rare cause of hyperandrogenism in adolescents and adult females. It's a differential diagnosis for PCOS. During the diagnosis, we use this kind of nomogram. It's very helpful in our clinics and in our meetings with the biochem colleagues. So basically, if the basal 17-hydroxyprogesterone, we have 2 nomograms based on the unit used. This is in nanogram per deciliter, whereas this one in nanomole per liter. So if the level is more 17-hydroxyprogesterone more than 100 nanomole, so usually that would be straightforward thinking that it is a CAH or if you take the nanogram per deciliter, it's usually more than 3,300. So basically, we take the 17, the basal one, and we take the simulated 17-hydroxyprogesterone. So patient will have a synactin test. Basically, we give ACTH, synthetic ACTH, and then we measure the stimulated 17-hydroxyprogesterone. So say, for example, this patient has had 400 nanomole per liter as a basal, and then with stimulation, you get it 4,000. So you are dealing with a classical CAH. Whereas if the stimulated is less than what is going on, so it could be non-classic CAH, or patients could have a small elevation of 17-hydroxyprogesterone, which considered to be carrier, and they would be asymptomatic, and here the normal population. We have another pathway from the American Association, and then you check the 17-hydroxyprogesterone assay, could repeat it to confirm if it's abnormal, and depends, there is symptom or there's no symptoms. If there is a symptoms, you treat straightforward. If there's no symptoms, you do the stimulation test with the synactin, as we mentioned earlier, or cosinotropin, basically synthetic ACTH. And according to the stimulated 17-hydroxyprogesterone, you can decide whether this patient depends on how high is 17-hydroxyprogesterone, whether you could consider the patient is unaffected and carrier, or patient is heterozygous, again, a carrier, there's no action to be taken, or classical, non-classical, and then you decide on treatment based on that. So from management point of view, depends on the age of the patient. During prenatal, we have set management, neonatal, and infancy. So prenatal management, say for example, there is a family with consanguineous history, and the first child was born already and was diagnosed with 21-hydroxylase deficiency, and they have a child already with CAH. Now, they came to the second pregnancy, and this the child is still inside mom's womb, and mom just came to know that she's pregnant. So is there anything that we could do especially if a female fetus, to reduce the virilization and the effect of androgens on her? Now, they said we can make a diagnosis quite early on by taking a CVS sample during the 9th to 10th week of gestation, or amniocentesis between the 14th and 16th weeks, to determine the sex first, and then to determine the genotype of the fetus. Now, if there is a chance for this baby to have a CAH inside the womb, there are theories talking about let's suppress mom's steroids to suppress baby's ACTH. So if we so let's give the mom a high dose of steroid to suppress baby's ACTH by giving like a dexamethasone. And now this is an ethical dilemma. So we are treating moms to trying to help the babies, and they said, according to this theory, preferably starting as early as 4 to 6 weeks of gestation. If it's a male baby, after you found out about the gender, then you could stop this dexamethasone. But it's mainly for females to stop the virilization that is occurring while the baby is inside the womb. Now, the dilemma behind that is, what are the effects of such high doses of dexamethasone that suppress the baby's ACTH? Are there any long-term effects? Now, the study is still a very small study, and so far the fears that there are issues about the memory and the CNS development, as well as the strength of the bones. So taken into this consideration, all these factors, still this method is not recommended, is not practiced widely by clinicians. For neonate, the management now usually happens when there is some sort of ambiguity of the genitalia, and that put the baby under the umbrella of disorder of sexual development, DSDs. So usually we should inform the parents that we have a doubt about determining the gender at the moment, so we should not assign a gender or name the baby at this stage. We need to carry on further investigation urgently, like doing a PCR fish or karyotyping to determine the SRY gene, and then further investigations like doing ultrasound pelvis to look if there is any uterus or ovaries, then surgical evaluation depends on the ambiguity of genitalia, some biochemical investigations like UNEs and monitoring the glucose, and 17-hydroxyprogesterone preferable to be done on the 3rd day of life. Now, if the patient is diagnosed with CAH based on those investigations, so we will start patient usually on fluid cortisone between 50 to 100 mics per day, with sodium chloride of 5 millimole per kg per day, and hydrocortisone 10 to 15 milligram per square meter per day. Now, if male neonate presents with salt-losing crisis, in addition to the biochemical investigations, if the patient in crisis will need replacement of fluids urgently and quickly, swiftly, given 10 to 30 ml per kg of normal saline over 1 to 3 hours, depends on how many boluses you're going to get. Maintenance and deficit to be covered over 24 hours with normal saline as well. And then if there is a hypoglycemia with the sugar below 3 millimole per liter, we usually give 2 to 4 ml per kg of 10% glucose. And we give a start dose of hydrocortisone 25 milligram intravenously, and then maintenance dose of 12.5 milligram 6 hourly until the patient will be tolerating either oral or GPs. And when the sodium is normalized, then we put patients on fluorocortisone sodium chloride. There are some practical tips. The hydrocortisone is administered in tablet form, which can be crushed and mixed with milk or liquid, and it should be given as fresh preparation before administration. We should not prepare the first dose in the morning and we continue that preparation and that solution for the evening dose. It should be freshly prepared with each dose. And other potent forms of steroids like prednisolone, dexamethasone are not recommended for use in early childhood years for the following reasons. First, it's not going to give a proper suppression in the morning serum 17-hydroxyprogesterone level, and it could affect the growth of the child. And with the potent steroids, patient easily can be overdosed and resulting in congenital features. It's very important after diagnosis to educate the parents about the condition. And from my practice, I spent with them at least an hour just for the sake of education, because I see that as an investment for the future. So a proper education, as well as provide them with a YouTube video that I made for them in Arabic for about 11 minutes, explaining when and how to give the 6-day dose and why we need to continue with the hydrocortisone. They should be given like a label to be used for emergency cases, as well as a bracelet or necklace or something like that. Our colleague from Great Ormond Street Hospital in London, they developed an app called My Cortisol, and there'll be a very useful app actually for patients to carry on their phone. So when if they are facing an emergency case, they could take their child to an emergency facility, and then if the ER doctor is not aware or familiar with the emergency cases, adrenal crisis and patient with CAH, there is a guidance for the doctor in ER what to do, what investigations, how quickly to give the fluid or the dextrose. And then patients should be given a written guidance as well at the temperature 38, at temperature 39, what to do, how to increase the doses, what doses to give. So basically all of that is given to our patients after breaking the bad news and telling them about the diagnosis and counseling. The follow-up to be arranged usually weekly in neonatal period, and once every month or 3 months during the infancy, and then every 4 to 6 months thereafter. URNs are not necessarily unless the child is not thriving, and usually we check the 17-hydroxyprogesterone and androgens biannually, and depends on the lab facilities that we have. You could check the run-in as well, and the born age annually. The height, weight, BMI, blood pressure with each visit. Now, the burden of the disease, as we know, it's a burden on the parents and burden on the patients. So on the parents, it's a shock for them at diagnosis. There'll be a worry over their child's genital anomaly, especially females, number of surgeries that could happen in the future, and anxiety over the genital surgery. For patients, of course, it's a burden. There's a disease burden on them because of the acute illness that could happen. Learning difficulty in some salt wasting patients that has been mentioned in the literature. Growth issues, poor growth can be happening in the first 2 years and overgrowth in 2 to 10 years. Early puberty, and if early puberty happens, there is a chance for the child to be short later on in the adulthood. Obesity because of the steroid urogenital problems, UTI, incontinence, and vaginal stenosis, all known complications and issues to happen in patients with CAH. Or about the psychosexual and the self-esteem, the confidence, the sexual orientation and activities, always issues about fertility in the future. So our goal of treatment basically to achieve normal growth, normal bone maturation, normal timing of puberty, good cognitive development, self-esteem, and of course, good quality of life. Treatment is to prevent long-term sequelae such as cardiovascular complications, fractures, testicular adrenal rest tumors, infertility, adrenal crisis, and sudden death. There was a good paper actually by Daf and his colleagues, and there was a good recommendation for patients who are presenting with high ACTH and they are being missed at the neonatal period, and they continue to have high ACTH. There is a chance for them to develop testicular adrenal rest tumor TARS, which later that is going to impair the testicular function and can cause oligospermia. So they recommended for beyond 5 years of age, all affected males should be screened for development of TARS by serial ultrasonography, because on the clinical examination, you may not detect the early lesions. So by ultrasound, you can find the hypoechoic lesions, and that could help you diagnosing the TARS earlier. And the current and novel treatment strategies in children with congenital adrenal hyperplasia, it was very nice article published in Hormone Research in Pediatrics recently, just this year by Anna Nordstrom. So trying to summarize all the available options for treating patients in addition to the steroids, hydrocortisone, glucocortisone, bilateral adrenalectomy to remove the adrenals. So meta-analysis of 48 published cases for different age groups ranging between 4 months to 56 years had shown that 71% of the patients would have improvement of their symptoms. That's fine, good, that's promising. However, the risk of adrenal crisis is much higher. It's 14.8 per 100 patients per year. And that is very concerning because it's almost triple the incidence of adrenal crisis when those patients did not undertake the adrenalectomies. So therefore, it is not recommended anymore to have patients going for bilateral adrenalectomy. And that was also mentioned in the Endocrine Society guideline. What about clonidine? Clonidine is modified release hydrocortisone. It consists of an outer coating that offers an immediate release of hydrocortisone, and there is another inner coat to provide an extended release of the steroid. It's a very useful, practical, because patients would have better adherence because it's usually given only once a day. But it has been made for patients with autoimmune Addison disease. It hasn't been made for patients with CAH. So it works for Addison disease, but it doesn't work for patients with CAH because the issue about that, and the argument is, it's not going to suppress the morning rise in 17-hydroxyprogesterone. What about other medications? We have corticotropin-releasing hormone receptor antagonists. We have the abiraterone acetate, which is anti-androgenic drug. We have the nivolumab hydrochloride, which is a selective acyl coenzyme A cholesterol or acyltransferase inhibitor. But all these medicines being used in the adults, not in pediatrics, so there are no trials in pediatrics. And even in the adults, still we don't know what are the long-term effects of these new adjunct therapies. If there's unknown long-term sequelae of them, then how safe are we going to use them in children? So at the moment, they are not recommended in pediatrics so far. And I think I have used my time. I should stop here and I'll take your questions if there's any.
Dr. Hussein, thank you very much indeed. But can I ask one question or two questions?
Yes, please,
okay.
Yeah.
How would you adjust the dose of hydrocortisone depending on 17-hydroxyprogesterone value? How would you go Do you oversupplement the gland, or do you
No.
permit some?
Yeah. So basically, you go by two markers: the 17-hydroxyprogesterone itself and the bone age as well. And ideally, we should not suppress the 17-hydroxyprogesterone completely. You should allow to have some 17-hydroxyprogesterone there, but it shouldn't be high. So it should be left within low normal. So that's how we adjust the dose and increase the hydrocortisone.
Low normal of the normal value for age, isn't it?
Yes, yeah.
Okay. And most of the time, I have my patient with CAH, bone age is extremely advanced. How do you go far?
So if it's advanced, means that this child is exposed to high androgens, and therefore our suppression wasn't great. So it's difficult to manipulate at this time. Some clinicians or colleagues, they do face, when they face these conditions, they try to delay the puberty and then intervene with the puberty as well, trying to give a bit longer time. And some of them want to be given growth hormone. The Endocrine Society, according to the published guideline consensus from 2018, they advise not to do this. So if it's advanced bone age, that's just misfortune to the patient, just leave him with that, trying to adjust the hydrocortisone to prevent further advancement of the bone age.
Dr. Hussein, sometimes I have some of my patients is bone age is 7 years, plus 7 years.
All right.
So we have to try all. I know it is off-label use, but if it is plus 7 bone age, what can I do?
Well, this is a tricky question.
Yeah,
it is very tricky. So that's why we say from the beginning, try to be very clear with the parents about the importance of giving the drug and diagnosing early to avoid going into this. I think if you reach that, the advance by 7 years is a bit tough situation. You are ending up as well as a patient. Just go with the things. You cannot do much at that stage.
Okay, thank you very much. Thank you.